add your name to the chat, your organisation and what you want to get from today's Lunch and Learn. Okay, so I'd like to introduce you to today's team. Okay, so you've just met myself. I'm Vicky Patel. I'm the chair of the National Quality Improvement Including Clinical Audit Network, and I'll be chairing today's session. Josie is our key speaker. Josie is the National Medical Director's Clinical Fellow at HQIP, and she'll be our key speaker for today. And then we've got Jordan Thompson, who's our chair of the North East Clinical Audit Network, NESAN, and he's our facilitator at today's event. So just to give you a brief overview of today's session then. So the theme of the day is patient safety. This is all about utilising clinical audit to reduce avoidable harm. We will be giving you the opportunity to ask questions at the end of the session. We'll begin briefly by touching on NQICAN's background and common purpose, and then we will be moving on to why Clinical Audit Awareness Week is important to our audit community. And we'll look at what patient safety is and how this aligns to clinical audit, touching on how, if used effectively, it can actually be a really powerful tool in reducing or eliminating clinical risks. We'll hear from Josie, our key speaker, and our Clinical Audit Hero winner will be announced. Then there'll be a short presentation followed by a networking opportunity, and we'll be closing this session by 2 p.m. Okay, so Clinical Audit Awareness Week then is run in conjunction with HQIP, and it's actually on behalf of our local clinical audit communities. So why are we all here then doing what we do every day? This is about high quality care for all. It's about putting patients and service users first, making a difference, helping patients when they need it most, and providing health and well-being to our local communities and all that we are within that. Behind our purpose are multi-factors that impact, and we must be aware of and consider this in all that we do every day. We are ultimately aiming to provide high quality and effective care to all in the right place, at the right time, whilst preventing harm and providing that best experience. But to get that right every minute of every day can sometimes be challenging. However, we do strive to try to achieve that where and when we can. We've got that duty to care. It doesn't matter what type of health or social care organisation that you're associated with, we're all here ultimately for that same purpose, to ensure that we do get it right, and when we don't, we take time to reflect, learn and share together. It's all about identifying improvements, measuring, implementing, evaluating, particular emphasis on equity and access, and sustaining those improvements. And this week touches each day on those drivers behind our programmes of clinical audit. The week also provides us with an opportunity to share, network and celebrate what we achieve through clinical audit every day. And we want to learn and share together on a much more wider scale. We want to understand the challenges to effectively getting the most from clinical audit as a quality improvement process. And we want to take time to reflect, look at what's working and maybe where it's not quite right. Set ourselves some objectives to take away from this week back to our own organisations, teams and patient service users. So let's shine a light on the impact clinical audit is actually making to improving patient care and services. We need to identify where our next destination is and how we're all going to get there together. So NQICAN is made up of 12 regional networks. Attendees at our quarterly NQICAN meetings consist of the 12 regional network chairs, 2 officer roles, which is the chair and general secretary, non-officers and co-opted members. And if you're not yet a member, please do get in contact and we'll direct you to your regional network chair. The chairs are all involved in Clinical Audit Awareness Week, and you'll see them interacting with you all across each day of this week. And we'll pop some contact details into the chat for you. The NNSF is a networking and sharing forum, and again, if you're not yet a registered member, head on over to the link and request to join. Becca's going to share the link and the nqi.can1@nhs.net email in the chat. It's a fantastic platform to discuss, share and learn together how we all use clinical audit for improvement. Now, NQICAN has a common purpose, and a forward plan. And the regional networks are actively involved in this, and they provide a voice into NQICAN from all types of health and social care organisations, and they take the voice back out to the networks from bodies such as NHS England and Improvement, HQIP, NICE, Getting It Right First Time, the Model Health System, Royal Colleges, other national clinical audit providers. It's all about getting involved, making a difference and solving together. NQI can have annual priorities and they link into task and finish groups to complete these. All of this is cascaded through the regional network chairs to their members. If you want to know more, head on over to the NNSF or get in contact directly with your regional network chair. And as I've already said, the contact details can be found on the NNSF, the NQICAN website, or alternatively drop an email to the nqi.can1@nhs.net email address. So we'd like you all now to join in with the Mentimeter, and Becca's about to pop the link into the chat. So if you click on the link and head on over to the poll, we're asking you one question. Think about from your perspective, what would utilising clinical audit to reduce avoidable harm and then improve patient safety look like to you? So Becca's going to share the screen of the Mentimeter. And if you click on the link in the chat, lovely, and head on over to your question, you can quite easily then just type in, what does this mean? What does this all mean to you? What does it look like?
Is the Mentimeter coming up for you guys?
Lovely, I can see that now.
Right.
Okay. We're starting to see people posting. Oh, lovely. Excellent. Yep. Learning from incidents and patient safety risks, identifying themes and trends. Yeah, compliance with local policies. Yeah, focusing audit activity on patient safety priorities. Linked to quality objectives.
Okay, let them answer. I don't care. Which website?
Oh, this is really good.
Oh, yeah.
Useful. Brilliant. Involving patients. Yeah, learning from past incidents, reducing those future risks. Lovely. Yeah, identifying risks and mitigating. Plan, do, act checks. Such a wealth of information here. We will be collating all of this so that we can share this more widely with you all. So I'll give you a couple more minutes to keep posting. We're going to touch on some of these as we move to the networking session with Jordan towards the end. This is really positive. We're all on the same page, aren't we? Sharing the learning. Identifying those key themes and trends. Just give you a couple more minutes. Triangulating data, that's good. You can put in multiple entries if you like. Don't feel that you can only pop in once. Wealth of information coming through. This is fantastic. Keep posting. Okay. One more minute, then we'll give you another minute just to keep posting onto the Mentimeter. For anybody that's joined us late, if you can just use the chat function to introduce yourself, your organisation, and what you want to get out of today's session. We're just posting on the Mentimeter. The link is posted in the chat. That's good. Okay. Am I right in thinking that the Mentimeter will stay open, Becca, if I go back to my slides?
I think so, yeah.
Yep, so you can all keep, for those of you that have just joined us late, you can still keep posting.
Shall I stop sharing it for now?
It will stay open, Vicky.
Lovely, excellent, excellent. So I will go back now then and talk to you then about defining patient safety, if that's okay with everybody. So we'll continue now. So in thinking about just the time that we've got today, because obviously this is quite a big agenda, so we're just going to touch on some key points, if that's okay. So our focus is how we can improve patient safety through clinical audit. And it is important to acknowledge links between effectiveness, experience and safety. All goes back to Lord Darcy's triangle. So patient safety is ultimately about a framework to keep patients safe. We're looking at preventing avoidable harm here, a framework that consists of multiple factors. We've got people, we've got systems, processes, the environment and much more. And behind all of these are multifactorial considerations, complexities, challenges, however you want to look at it. For example, behind people, we need to think about culture, behaviour, capability, capacity, motivation. Think about those processes. How many SOPs, guidelines, policies and procedures do we have behind processes? And of course, we've always done it like this response that you sometimes meet. So all of these can have an impact on patient safety, but if the framework's strong and effective, we should be seeing reductions in the occurrence of avoidable harm. All of our organisations should have insight and understanding of safety across the whole system by drawing on that intelligence from multiple sources of patient safety information. We have to be learning from this information to enable improvement, and we have to be able to use it to identify clinical risks so action can be taken to keep our patients and service users safe. So there are a number of high-profile publications on patient safety, including the National Strategy, guides, tools and resources, alongside learning and sharing platforms and knowledge hubs, such as the NHS Futures platform. So why look at patient safety when we talk about clinical audit for improvement then? And I'm probably going to ask you to think about some of these points that I'm going to raise as we move through the week, looking at other topics in relation to clinical audit, because everything that we're about to touch on relates to how effective we can make clinical audit in achieving its true potential of being such a powerful quality improvement tool. Nothing works in isolation, pretty much in the same way that in healthcare we work in teams. There are always underlying factors or wider contributors to where we end up and how that outcome looks. I've just mentioned to you that behind people we have a whole range of factors that can impact on patient safety and outcomes. So just wanted to touch on behaviours. And how many of you have heard of Maslow? Maslow's really, really popular in the nursing profession, but it's made up of a hierarchical level of needs. And if you look at these levels, we've all got needs. What do you as an individual need to be in place so that you are in a good place yourself? What needs to be fulfilled in order for you to be at your best and able to contribute? There's been loads of work published on psychologically safe environments recently, and that's so that we can all feel enabled to contribute and make a difference. So creating a psychologically safe environment means safety and innovation, collaboration and communication. They're really important. Think about who do you include or exclude and why. What are your unconscious biases? How are they impacting on your behaviour? Do you make failure acceptable in order to learn? Our environments are created by our leaders, but the team actually contribute to it as well. Now, in order to learn together, we've got to accept that if we get it wrong, it's not all bad. If we get feedback, it's not negative. It's about exploring to understand, learn, and make it even better even. That's where clinical audit comes in. We always say clinical audit is the most robust quality improvement tool. We know what evidence-based practice we should be delivering, but behind implementing evidence-based practice is a whole bunch of different elements that must be in place and working well. And what happens when things don't go as planned and either we have a near miss or a patient experiences avoidable harm? The clinical audit utilised in a psychologically safe environment is such a valuable learning tool. At all stages of clinical audit, we're actually reflecting and learning, utilising our innovative sides to make patient care and services safer, more effective, and ultimately providing the best experience for the recipient. And with that, we mean both patients and service users, but the staff and the team as well. Team members impact on the learning environment. They may be quick to shoot down ideas, and this impacts on learning and safety, and we shouldn't be fearful to ask. We need that collaborative learning environment to learn and grow together. So just bear in mind that psychological safety runs throughout this whole week. It's about challenger safety. It's about challenging people to find the issues and the problems. But we do all have a desire to feel safe, and just look at Maslow. We should be applying this in all that we do. Now, we work in or are associated with health and care, and that means we work with people. So if we're involved in the world of quality improvement, then we've got to create, enable, support an environment where we all feel safe to bring out the best of our abilities and to learn and improve together. So we must consider how we all contribute to being inclusive, recognising when things go wrong, not punishing, encouraging questions, participation, those ideas and innovation, and listening to others as well, not just telling. So I just wanted to touch on patient safety and civility, really, and there's strong evidence that kind and compassionate care leads to better patient outcomes. There's also strong evidence that the highest performing teams create psychologically safety within their work. Now, the NHS England and NHS Improvement Civility and Respect programme, they bring you a Kindness into Action masterclass, and this is about kinder cultures leading to safer care and better outcomes. Now, collectively together, we must ensure that staff feel valued, supported and empowered to carry out their work, and we should be role modelling that as leaders within our teams and our organisations at all levels, and making sure that we're exhibiting those behaviours as well. It's all about a culture of civility and respect, and our NHS People Plan talks about this throughout. So teams that are kind and compassionate, value each other's contributions, they do actually have lower patient mortality rates. And we've all got a duty to care and a duty to look after one another, because we know this impacts on the care and delivery of our services. Now, Health Education England are looking quite actively at learning environments clinically, as this is about building the workforce of the future. And the National Patient Safety Strategy sets out a framework for us to learn and improve, investing in all levels to make healthcare a safer process and to ensure that we act and learn. So I just want to refocus now, as we're here today to look at how clinical audit can help to drive that patient safety agenda when we utilise it effectively. And if you look in all of your own organisations, there's a whole programme of improvement learning, assuring and monitoring for patient safety. And if you look at the image here, we're talking about things like the CAAW, the Clinical Outcome Review Programme, the LEADER, the Learning Disabilities Mortality Review, the National Confidential Inquiries into Patient Outcomes and Deaths. We've all got structured judgment review processes in place. We've got the prisons and probation ombudsmans. We've got the HSIB, the Healthcare Safety Investigation Branch. So there's an awful lot of reviewing and monitoring and data as a result that we can access for clinical audit, but that we can also feed back clinical audit into as well. So if you think about your mortality and your learning from deaths, the frameworks in all of our organisations to learn about where we did everything possible and in the right way, at the right time for that individual patient, and when we didn't, what can we learn? What can we change to prevent that happening again for someone else? Any themes in what we're finding? And how can we feed that into our clinical audit programmes to really show that we're learning and signing up to making improvements? Think about your complaints, your claims and your inquests. Learning and aligning with the clinical audit programme to treat or eliminate the risks that we've identified when things didn't go as planned for either the patient, the family, the carer or staff, the team, the organisation. Clinical audit, when it's fully utilised, is a powerful tool to make a difference. What do our getting it right first time reports tell us? What's our wider data in the model health system telling us? And what else do we know? We need to triangulate to understand the context to get the full picture. And as we move through this week, we're going to touch on topics aligned to patient safety. How do we engage and involve those that use the services we provide to fully understand the things from their perspective? How does we as healthcare teams and wider stakeholders learn and then effectively influence change to make things even better? And how do we start to reduce inequalities for certain groups or individuals to ensure we do get it right for all at the right time, ensuring that we do reach everyone? And given all that we're going to hear and contribute to over the week, how can we build on that further and strengthen what we do every day to future-proof what we do? And all of this contributes to patient safety, so many layers. But let's bring it back a level now and take a closer look at aligning clinical audit and patient safety. So if we look at that in a little bit more detail and think about the stages of clinical audit for improvement, is your topic in response to a patient safety concern or issue? How proactive are we in working with patient safety colleagues to ensure that clinical risks are regularly reviewed and included on the clinical audit programmes? Are we measuring the right elements to give us the picture that we need? If this audit's really important enough to be included on the programme, then we must get that methodology right. We need to pull from the right data sources and not in isolation. Triangulation will give us the full picture and context. We need to make sure we've got the right people involved at the right level with the right knowledge to understand what the data is telling us. Do we have the right skills, knowledge and capabilities involved in this audit? And are we identifying clinical risks in the outcomes? Who are we telling? Did we already know about this clinical risk? And then are we making the right decisions in taking action? And what action do we think is appropriate? And how do we know that that action won't actually cause any harm in itself? How timely do you undertake action based on your clinical audit results as well? And how do we know that that change will be sustained? Is there a risk that practice or behaviours will revert back? And how will we know? So when we look at all the stages of clinical audit, regardless of whether the topic came from a patient safety issue to begin with, safety is woven through the whole of the process. And if we don't utilise clinical audit effectively, we could actually miss potential risks or even cause them as a result. So finally, I just wanted to touch on, within your organisations, considering your clinical audit findings, does your clinical audit strategy have a clear objective to align to patient safety? Does it have a clear focus on reducing harm? Does your clinical audit programme include clinical audits in response to patient safety issues or concerns? And does your clinical audit findings highlight clinical risks? Are these added to the risk register with a level of risk assigned? And have the findings been triangulated with other patient safety data and registered risks? And actually, have you actually escalated those to the right roles, groups, committees to take ownership of those clinical risks highlighted through that clinical audit? And when you come up with that improvement action plan, have you aligned it to other patient safety improvement actions within your organisation or even wider within your system if you start to think about your ICSs? And do the findings from any re-audits or remeasurement confirm that the level of risk has been reduced or eliminated and further prevented harm? Or have you got other available data that can evidence the improvement action plan having reduced or eliminated that level of risk? So I'm going to now introduce Josie to you and ask her to share with you her experiences on clinical audit and patient safety.
Hi, thanks Vicky. So good afternoon everyone. Thank you for the opportunity to speak today. So I'm a National Medical Director's Clinical Fellow at HQIP and my background is that I am an obstetric and gynecology trainee. So I'm first going to provide you with a refresher on the national approach to patient safety, touching on how clinical audit is involved, and then discuss in more detail the use of national and local clinical audit in improving patient safety using an example from maternity care. Next slide, please, Vicky. So why are we here? It is human to make mistakes, so the NHS needs to continuously reduce the potential for error by learning and acting when things go wrong. Patient safety is the avoidance of unintended or unexpected harm to people during the provision of healthcare. When reviewing situations where unintended or unexpected error has occurred, the chosen action should be the one that is most likely to reduce the chances that the error is repeated. The systems approach underpins the NHS patient safety strategy, including the new Patient Safety Incident Response Framework. The NHS Patient Safety Strategy was published in 2019 and has 3 themes underpinning it: insight, involvement, and improvement. Insight relates to improving the understanding of safety by drawing intelligence from multiple sources of patient safety information. Improvement refers to equipping patients, staff, and partners with the skills and opportunities to improve patient safety throughout the whole system. And improvement means designing and supporting programs that deliver effective and sustainable change in the most important areas. The most obvious area here that involves clinical audit is insight, but obviously involvement and improvement are closely interlinked. Following on from the Patient Safety Strategy, the Patient Safety Incident Response Framework, also known as PSIRF, was first published in 2020. PSIRF is a new approach to incident management, which facilitates inquisitive examination of a wider range of patient safety incidents in the spirit of reflection and learning, rather than as part of a framework of accountability. Early adopters have been following the framework for some time now, and whilst there have been COVID-related delays, it is due to be rolled out widely later this year, replacing the serious incident framework and supporting insight generation at the point of care. As part of the PSIRF, NHS healthcare providers will need to develop their own patient safety incident response plan, which in addition to patient safety incident reporting and patient safety incident investigation, includes alternative responses to investigations. This includes actions such as instigating safety huddles or after-action reviews, as well as clinical audit. Some incidents, such as never events, will always need a patient safety incident investigation, but others will be determined by your local priorities. The aim is that this will promote quality local investigations that are more open, inclusive, and effective. Next slide, please. All organisations should now have a patient safety specialist that will provide leadership and oversee and support patient safety activities across their organisations. The National Patient Safety Syllabus was released in the autumn, and e-learning modules relating to the first 2 levels of practice are now available on e-learning for health. The syllabus has 5 key domains listed here, with 4 key themes running through them: systems thinking, human factors, risk expertise, and safety culture. An example of the role of audit includes ensuring process reliability and safety assurance as part of the human factors, human performance, and safety management domain. So moving into maternity care, patient safety has a huge role and a long history. The maternal mortality confidential inquiry is the longest running and most successful medical report in history, established in 1952, shortly after the inception of the NHS. At that time, there was a maternal mortality rate of around 90, that's 90, per 100,000 women giving birth in the UK. To put that into context, the maternal mortality rate from the most recently published Embrace report was 8.8 per 100,000. Obviously, maternal mortality is not the only concern in maternity care. Obstetric incidents can be catastrophic and life-changing, with related claims representing the clinical negligence scheme for trust's biggest area of spends. Of the clinical negligence claims notified to NHS resolution in 2020 to 2021, obstetrics claims represented just 11% of clinical claims by number, but accounted for 59% of the total value of new claims. That's almost £4.2 billion. The NHS Litigation Authority introduced a risk management programme specific to maternity care in the year 2000, with CNST, an insurance assessment scheme, being established. The scheme gave financial incentives to maternity units that complied with CNST standards, many of which required specific clinical audits. In 2017, the NHS Litigation Authority was rebranded to NHS Resolution, and in 2018, CNST pricing was aligned with the Maternity Incentive Scheme. Each year, 10 safety actions are identified, and trusts that comply with these are able to recover the element of their CNST contribution that went into the Maternity Incentive Fund, plus a share of any unallocated funds. The maternity incentive scheme is in its 4th year, and current safety actions include aspects of workforce planning, multidisciplinary training, compliance with Saving Babies' Lives Care Bundle version 2, submission of data to the Maternity Services dataset, and use of the National Perinatal Mortality Review tool, amongst others. So I'd now like to move to discussing how patient safety and audit may work in practice, using the example of small for gestational age babies. Babies are defined as small for gestational age when their birth weight is below the 10th centile on a growth chart. Over the past 20 years, there's been increasing evidence that fetal growth restriction, which is a subset of small for gestational age, is associated with stillbirth, neonatal death, and increased perinatal morbidity. In 2015, the Perinatal Embrace report on term antepartum stillbirths, meaning the baby died prior to labour, found that around 1 in 3 term normally formed antepartum stillbirths are related to abnormalities of fetal growth. In 2015, the government made an ambition to reduce stillbirth by 50% by 2030, which was subsequently updated with the target to achieve this by 2025. Now, for the next slide, please, Vicky. The Saving Babies' Lives Toolkit was produced to help reduce perinatal mortality across England. It is a co-developed care bundle for maternity units, produced by clinical experts and representatives from the Royal College of Obstetricians and Gynaecologists, the British Maternal and Fetal Medicine Society, and NHS Improvement. NHS England engaged extensively with stakeholders, including the Royal College of Midwives and the Maternity Transformation Programme Stakeholder Council. The second version of the care bundle has an emphasis on continuous improvement. Version 2 of the care bundle includes 5 elements of care that are widely recognised as evidence-based and/or best practice. The second element is the risk assessment, prevention and surveillance of pregnancies at risk of fetal growth restriction. Interventions include prevention with the use of low-dose aspirin and/or smoking cessation when indicated, risk assessment and ultrasound surveillance of at-risk pregnancies, and surveillance with measurement of the pregnant abdomen in the low-risk population. Guidance on the management of suspected for small for gestational age and growth-restricted fetuses is provided, with the recommendation that induction of labour is offered at 39 weeks or earlier, with the exact timing determined by both the degree of growth restriction and other maternal and fetal risk factors. So I'm sure you will have heard of Ockenden report into maternity care at Shrewsbury and Telford Hospital NHS Trust, which was published earlier this year. This reviewed the care of almost 1,500 families, many of whom had poor maternity outcomes. In the report, they acknowledged that monitoring fetal growth is an integral component of safe and effective antenatal care. Sadly, they detail several cases of antepartum stillbirth where the baby was found to be severely growth restricted at birth. When these cases were reviewed, it was often found that either guidance in referring for scans had not been followed, or staff had made errors in plotting measurements, both of which, if done correctly, may have led to a different outcome for these families. These findings led to the 2 recommendations detailed on the slide, both of which involve audit. Next slide, please. So what is the role of national audit? National audit has an important role at looking for unwarranted variation across the country, which may either indicate a problem or excellence, as well as monitoring progress against clinical standards. The National Maternity and Perinatal Audit collects data on the number of small for gestational age babies that are born at or after 40 weeks as a proportion of all term small for gestational age babies. The spine chart pictured is an example of the data that is freely available on their website, where you can review the performance of any selected trust against the expected range and national mean. For example, this spine shows that the selected trust is within the expected range for the measure of small for gestational babies born at or after 40 weeks, being slightly below the national average with an adjusted mean of 47.8%, whereas it does show that the overall range across the data was from around 30% through to over 80% across the country. Despite interventions, national data still shows that around half of term babies who are small for gestational age are born at or after their estimated due date. And I'd just like to note that a new report is due to be published by the NMPA later this week. So moving on to the final slide, what does this mean for you and me? Why should we be performing audit locally when we have national audit? Should we be doing it just to comply with mandatory reporting? As an obstetrician, sometimes when there are endless lists of audits that need to be completed, it certainly feels this way. Some audits will always be necessary and important, but for patient safety, we need to get smarter with our use of clinical audit, especially if it's a resource-intensive process. It may be that part of the patient safety incident response plan that we replace multiple investigations with instead an audit of a subset of patients with a specific outcome to review if particular process measures might be causing the problem. It may be that we review our data and see that we're an outlier and need to explore in more detail. It's really important to consider context and don't look at one measure in isolation. For example, in maternity care, if your induction of labour rate is higher, then you may expect that you'll be managing to deliver more of these small for gestational age babies by their due date. Is this the case? But if so, does this mean you're inducing some women unnecessarily? Are you seeing other problems in your data? Is the measure evidence-based? Unfortunately, sometimes the evidence is lacking for what may be felt as a good outcome, and we've unfortunately seen the results of this in maternity care. Shrewsbury and Telford Hospitals NHS Trust, the subject of the Ockenden Review, was celebrated for their low caesarean section rate in the past, but sadly it's now come to light that it was likely that this was contributing to poor maternal and perinatal outcomes. NHS England has recently contacted trusts with clear guidance to stop using total caesarean section rates as a means of performance management. Moving back to our example, if there's either a rise in stillbirths or the rate of small for gestational age babies being born at or after the due date, then an audit into antenatal care, looking at process measures such as appropriate risk assessment, monitoring and subsequent management may be very useful. But for every data point, we should know why we are collecting it. When looking at this data that will hopefully give you a why there is a problem, you then need to aim to identify systems-based improvement targets and interventions. As we all know, just telling people to do something doesn't work very well. Change the system. For example, embedding the risk assessment process in the booking visit if this is where people are being missed, or reviewing how people are slotting into the pathway of serial ultrasound surveillance and making this process more user-friendly if people are being lost at this point. Equally, you may find that capacity is an issue, but as this is a national safety priority, there may be a case for increased fundings. Always consider the next step, the so what. Engage with your teams to find innovative solutions, make a change, and we can work to improve patient safety and outcomes. Thank you. I've now got a couple of minutes, I think, that we can take some questions.
Okay, thanks, Josie. That was fantastic to hear that both from the national and the local context as well. So shall we move to seeing if anybody's got their hands up for questions? I'm not seeing any hands at the moment.
We can always take things in the discussion. I think people might be eagerly waiting for the awards.
It's absolutely fine. So let's move boldly on then, Josie.
Okay, so I really would like to thank everyone for their entries this year into the Clinical Audit Hero Awards. We had a really large number of entries for the Patient Safety Hero Award, and I'm excited to be kicking off the awards today. So without any further ado, I'm pleased to announce that the winner is the Critical Care Audit Team at East Kent Hospital's University NHS Foundation Trust. Unfortunately, they're unable to be with us today to accept their award and present their audit. They identified a patient safety issue with the placement of nasogastric feeding tubes and used audit to identify problems and instigated a system change to improve safety. Judges were particularly impressed with their scientific approach to identifying problems and implementing change. Well done again to the Critical Care Audit Team at East Kent. I'd now like to highlight another entry that the judges have commended. Corinne da Costa, an advanced neonatal nurse practitioner at Samwell and West Birmingham NHS Trust, was nominated by a colleague for her work on neonatal safe sleeping. The judges particularly liked the involvement of parents from the start of the project to make important changes. Congratulations, Corinne. I'd really pleased to give you this award, this commendation, and like to hand over to you now so we can hear more from you.
Hello.
Hi, Corinne.
Hi, can you hear me okay?
We can.
Okay, thank you for that award. It's lovely to get some recognition. Myself and the whole team, we've worked so hard on this audit and just improving care for our babies. So yeah, it's lovely to get some recognition. So, as you said, my name's Corinne Da Costa. I'm an advanced nurse practitioner on the neonatal unit at City Hospital. My audit was on safe sleeping of our babies on the neonatal unit and how we can reduce the risk of sudden infant death syndrome. So, next slide, please. So, with any audit, we have to identify a problem. So our problem came from a patient safety alert, and an investigation found that we had inconsistent positioning of our babies who were nursed in cots. We had a lack of adherence to safe sleep guidance that was out there, and we had no official information or signposting for our parents. And we also found that we had sporadic documentation also. So if I can just show you this picture on the right, sorry if it's not very clear for everybody, but this was a picture taken from Twitter of quite an influencer, Miss Kim Kardashian, and this is a picture of her second baby that she'd had a couple of days after he was born. So to anybody who is on social media, any new parents, you know, anxious parents, parents of those who have got babies on the neonatal unit, you'd look at this picture and think, oh, great, you know, we've got a sleeping baby in a cot. She's got a nest there and bumpers. You know, you're going to strive for this and think that this is an okay way to nurse your baby at home. But actually, those that are in tune to safe sleeping, we know that actually this isn't appropriate. So we can see that baby is in a nest or a pod, it's otherwise known as. Baby is wearing a hat. There is cot bumpers around the cot, and there's also loose fitting blankets overlying on the baby. The one protective factor that we can see is that there is a pacifier in the cot. So as I said, parents will see this and they'll want the best for their baby, and they'll think that, oh, Kim Kardashian has a baby in a nest and that's okay for me to do. But actually, copying these behaviours won't be the best thing for their baby. So the aims of the audit was to review practices on the neonatal unit in babies that are above 34 weeks gestation and are nursed in open cots, and just to see if we were adhering to national and local guidance and therefore reducing the risk of sudden infant death. So next slide. So if we can just define then sudden infant death syndrome, it's a sudden and unexpected death of a baby under 12 months of age. In the UK, it does affect around 200 babies every year, which is a very high number, but SIDS is actually classified as being rare. So the cause of SIDS is unknown, but for many babies, it's likely that a combination of factors relating to pregnancy and birth and their sleep environment or genetics and any recent infection, can be a factor. These vulnerabilities can be increased by them being born early or having a low birth weight. So this puts a lot of our babies we see on the neonatal unit at risk. Fortunately, there are some things that we can do to reduce the risk, such as the sleep environment that we're putting our babies in, and also the positioning in the cots. And that's the most modifiable factor, and that's what this audit focuses on. So next slide, please. So for the definition of the standards, they were taken from the neonatal unit guidelines, from our developmental care plan, and also the most recent Lullaby Trust guidelines. And for anybody who doesn't know the Lullaby Trust, it's a charity that promotes safe sleep, and they've done a lot of work to reduce the incidence of SIDS. So we put all the factors together for safe sleeping and came up with our criteria. So babies needed to be feet to foot in the bottom of the cot. They needed to be flat on their back in a supine position, in a flat cot with no elevation. They shouldn't be swaddled, and they should have less than 3 hospital grade blankets on, and they shouldn't be wearing a hat. They shouldn't have anything in the cots with them, no nest or props, teddies or anything else in the cot with them. So these were translated into what our babies were going to be assessed against. Next slide. So the methods of the audit were the same for both the pre-audit and also the re-audit after making some changes. So we'd determine the criteria, which I've mentioned on the previous slide. So the 8 criteria that we needed to be, and we'd set the pass rate as being 100%. We obtained trust audit approval, and we'd aim to capture 100 observations of babies that were more than 34 weeks and being nursed in open cots. We set the exclusion criteria, and these are babies that would be nursed in their cots in a particularly different position to all the other babies, because they were refluxing, because they had tone problems, or if they had recently had routine immunizations. So this was an ad hoc observational audit, which was carried out by myself, and it was just done whenever I was on shift. So it was unannounced. I'd either do it at the beginning of my shift, so come in a bit earlier, or at the end of my shift, so I left a bit later. And what I'd do was just walk around all the babies that were in cots, making sure that they met the inclusion criteria, and then assess them for the criteria in the previous slides that we went through. The findings were then entered onto an audit spreadsheet, and the observations were reviewed and the results were compiled. Next slide, please. So just to make it easier, I have put the results side by side, just for comparisons reasons. So on the bar chart on the left-hand side shows us how many babies were 100% compliant. So how many babies met each of the 8 criterias. So the grey bar on the left-hand side was the audit done in 2019. And you can see that just under 6% of our babies were 100% compliant and safely sleeping in their cots. So this was definitely an eye-opener, and it made me wonder, how would we not had a patient safety alert before this point, really? And then the yellow bar shows us 2021, and this was the re-audit after we'd put in a number of different measures, which I'll talk about shortly, and shows that we were actually 70% compliant. So we'd made a massive improvement, which was great for us all and as a team, really, to show that all our efforts, our blood, our sweat and tears that had gone into this has made such a difference for our babies and their families, and not just the babies and families on the unit, but also once they'd been discharged and gone home and in the community. So on the right hand side, you can see the bar chart of each of the individual criterias. So the 8 criterias are running along the bottom, and you can see that we had made improvements across the board, really, with everything, but mostly we'd made the most improvement in keeping the cot flat, removing hats from our babies and not swaddling them, and also removing toys from the cots. And these are things that were standard practices for any baby that was in a cot. You know, we'd always put their cot on a tilt. We'd always put them in a hat to keep them warm. And we'd also always say to parents, oh, bring in a little toy from home, and, you know, you can put it in the cot with your baby. But actually, these aren't best practices. So next slide, please. So I suppose you'll all be asking, how did we achieve this really? So we'd gone right back to basics. We'd looked at the developmental care plan that we had in place, and also the unit safe environment guideline, and we updated it in line with the latest Lullaby Trust guidance. So all the babies on the unit that were in cots that didn't need full cardiorespiratory monitoring were actually put on apnea monitors until they were discharged. So previously, at 34 weeks, these babies would have been taken off apnea monitors, but we decided to keep them in just for a bit of reassurance, really. We'd made cot cards for the babies who were medically exempt from the safe sleep criteria. So those that were refluxing or had tone issues, then you could see at a glance at those babies, we weren't necessarily sticking to the rules for those babies. Education was a big thing in this audit that we'd done. So lots of staff teaching, and also for our parents, most importantly. So the staff teaching was on in-service study days, which is for the multidisciplinary team. So everybody was getting the same training. On the foundation program for our new starters and band 5 nurses, and also for the nurses that were doing the intensive care course as well. We had regular reminders for all staff via email and effective handover, making all the information accessible for everybody. We also made posters to go up on the wall in our special care rooms, where most of our babies were nursed in cots. And it's just like the poster you can see on the right-hand side, and that just acts as a visual reminder really for staff and parents also. We were signposting our parents to Lullaby Trust, because we know that the Lullaby Trust have the latest advice and guidance. So we know that, you know, the parents will be doing the right thing. The Lullaby Trust posters we put into parent areas, so the sitting rooms and the kitchens, anywhere parents would be, we'd put some of these posters up. And also, because in Birmingham, a lot of families, English isn't actually their first language. So we made sure that they had access to the Lullaby Trust literature in a variety of languages. And we'd also improve the documentation. So for our babies that we said were medically exempt, we'd make sure that it was clearly written in the notes. And also when we had conversations with the parents, we'd make sure that it was fully documented in the notes also. So with anything else, we can always do better, and there is always room for improvement. So in moving forward, we are going to be taking up what is called STALK. So that stands for Supportive Training Offering Reassurance and Knowledge to Our Parents. And it's a parental education platform which enhances signposting and information given to parents. And it's not just on safe sleeping, it's on basic life support, smoking cessation, and also the signs of illness. And this is aims really to reduce mortality in our infants. So Neonatal BadgeNet, which is a documentation app that we use on the neonatal unit, and this is where we will be documenting all our conversations. We're also going for, as a unit, the Bliss accreditation and baby friendly accreditation, and these are charities really that give us standards to work towards and keep us moving things forward. And then eventually, hopefully, we will have a re-audit and see how much more improvement we can make. So that was my audit. Thank you.
Just going to take the slides down for a minute there. Thanks, Corinne. That was
Thank
absolutely
you.
that was really, really good. And I'm just going to open the floor up to see if anybody's got any questions. If you want to raise your hands. I do have a couple myself, Corinne.
Okay, that's fine.
I mean, in case. Oh, hold on a minute, Sue Arnold, you've got your hand up. Do you want to go first?
Yes, good afternoon. Thank you very much for that. It was really, really good. I'm an ex-neonatal nurse quite a long time ago, but I've always kept my interest going. I'm just interested, I did put it in the chat, whether or not your work has been shared with the neonatal networks around the country and also the academic science networks. I know Birmingham, are you Black Country or?
Yeah, we are Black Country.
Yeah.
Yeah.
So just wondered what you've done about that, because I did put something in the chat to say that part of your change, your big change, must have been around the culture of habits of years, because staff tend to stay quite a long while, you know, around your toys and things like that in cots and incubators. So I think it's well worth sharing much wider.
Yeah, it is worth sharing. You are right. I'm just in the throes of seeing who is interested in taking up this project. So our clinical audit lead at the hospital, at City Hospital, sorry, Rebecca Kershaw, she is doing really well in signposting me in places that may be interested. I am also the developmental care lead, so we have a meeting coming up in a couple of weeks, which I will be sharing this work and seeing what everybody else does, really, and trying to benchmark and see where else we can make improvements. Is there something really obvious that I'm missing that could potentially bridge the gap and get us closer to 100%, really?
It's fabulous. Victoria, you're from Sheffield Teaching Hospital, so I used to be governance nurse and the lead for neonates, and I just think it would be fabulous to start off with some of the big tertiary centres to roll that out, and also get it published in the Nursing Times. They love all that, and actually we've been lacking in professional publication around things that truly can touch both nurses, midwives and families at the benefit of babies as well.
Yeah.
Excellent. Well done.
Thank you so much.
Thanks, Sue. That's definitely worth mentioning. We need to get this disseminated as far and wide as we possibly can.
Yeah, absolutely.
And everybody that's on the call today, making sure that actually we do take this back to our own organisations, like you say, so that we can make our staff aware of it. I thought it was fantastic, Corinne. I love the innovative way that you've involved and engaged the parents. You're making change in action, aren't you, as you're doing, which is brilliant. I was just going to ask one question around, were there any particular standards that carried a greater risk, thinking about your overall compliance of improving you to 70%? Looking at your standards across the board, actually, were there any in there that were carrying a greater risk against any of the others at all for your focus as you move forward with your changes?
No, I think they were each. I think it comes as a combination. I don't think there's any one thing that, you know, makes it a greater risk. I think it's everything in combination, which is why we'd set the pass rate as being 100. I don't think we could have said, you know, it's okay if we're not doing one criteria over another. It really did need to be everything.
Yeah, that's brilliant. That's really good. And then I was just thinking about whether you were thinking about moving to continuous measurement and plotting over time as you start to think about continuous measurement going forward.
I hadn't thought so far, but I'm open to seeing where we can go with this.
Yeah. Excellent. Right, we've got a couple more hands up. So Sarah, your hand was up first. Sarah Chesel.
Thanks, Vicky. The chat's really hot at the moment, but there is a question from Yvonne Jones at 1327. Any issues with maintaining body temperature when removing hats, as these were traditionally seen as important? Just wanted to highlight that one for you.
Yeah, so we didn't have any temperature issues because our criteria for going into a cot in the first place is quite rigid, and we really do tend to stick to the 1.6 kilos for weight and already maintaining temperature in an incubator set at its lowest. If there were any problems, then these babies would go back into an incubator if there were any concerns. But no, overall, there wasn't many babies that were needing to bounce back into incubators.
Brilliant, thank you. And Carl, you've got your hand up. Carl Walker.
Hi, thank you. Well done, Corinne. It was a really good closed loop project, I would say. And
thank you.
I think linking it into the the theme of the session, it was nice to look at your adverse events and patient safety elements of patient outcomes as well going forward. And also, can you look at data that might be in the national neonatal audit as well? So because that might help with Vicky's question around the continuous monitoring. But
absolutely, yeah. I think in moving forward, I think there's a lot of scope for this to go. Originally, when I first took up the project, I did think, it will just be a one-off audit, see where we're at and what we're doing, and didn't ever plan to need to have to make so many changes and so much teaching, and for the re-audit as well. So much more work has already gone into it, which I just didn't anticipate. But yeah, it seems to be an interesting topic, definitely.
That's brilliant. Thanks, Corinne. It's fantastic. Fantastic to hear about it. So this now nicely moves us on into our next section of the Learn at Lunch, and I'm going to hand over to Jordan now. As I mentioned at the start, Jordan's our regional network chair for NISAN, the North East Clinical Audit Network. So Jordan, over to yourself now for this part of the session.
Yeah, thanks, Vicky. I've been watching the chat closely throughout the whole meeting and making notes as we've been going through, and there's been lots of discussion already. But I thought it would be good to come back to a couple of points that people raised earlier on, as well as your slide that you posed at the end of your session, where you asked people to think about a couple of questions moving forward. And if we have a little bit of a discussion around those questions, then it might answer some of the people in the chat earlier on who asked some questions. So I would be interested to know how many of us out there, how many teams out there are actively working with our patient safety teams and our organisations and risk management teams to really work on that triangulation with clinical audit and patient safety. Talking from experience, one of the organisations that I worked at, the patient safety and risk management team were part of our structure, so it was easier for us. Patient safety and risk, they fed into the same sort of directorate. We worked closely with the DATEX lead to get information on incidents relating to clinical audits that we were working on, things like that. Clinical audit was pretty well embedded into things like SI action plans, that sort of thing. So whilst it's probably not the same in every organisation, it would be interesting to know, are there organisations out there who think they have done it quite well and they have got quite a good link with patient safety teams? Because that seemed to be a question that a couple of people raised earlier. How are we linked in with patient safety? I don't know if anyone wants to give an example of how they do it in their organisation.
Should we ask you to raise your hands if you're willing to share?
Oh, we've got a couple of people. I'm not sure who was first. If we go with is it Alan?
Yes. Hi. Hi, everyone. My name is Alan, and I work in a private healthcare institution. A lot of you, I assume that you're all working within the NHS. But with regards to your question, Jordan, for us at Circle Health Group, we operate more than 50 hospitals around the country and predominantly around the countryside of England and Scotland and Wales. We do link closely because we are sitting in one governance and quality team. So we've got me as the audit lead, and then we've got the patient safety lead, and we've got the complaints lead, and then we do have the quality improvement lead. So every month, and we just started this project, which works really well, and it's just 3 months since we started this. We are trying to look at triangulating all the data together, and it's interesting to know that, for example, for me with VTE, if I have an exception of VTE risk assessments with my audits across some of the hospital sites, it's interesting that there's also something that's picked up by the patient safety lead on the increased incidence of patients developing DVT, or sometimes there is also a link to patient education, wherein sometimes there might be a little bit of a complaints in there saying that patients were not given enough information. Although the complaint side of things is not really very closely linked, but it does link somehow. And yes, it does work really well, and we're just quite excited for how this project will flourish as the months go by, as we try to see things, and it's kind of open doors of discussion, encouraging everyone from the team to pitch in. So it does really it works for us.
Yeah, it probably is easier when the teams are so closely linked, or they're under the same sort of management structure. It probably does make it easier.
Right.
Kay, did you want to say something?
Hi, yeah, just a similar structure to yourself, Jordan, at RDash. We sit in a team under nursing and quality, so patient safety is part of that. So we will get work that comes from SIs, or if there's clusters, then we will be asked if we can do a piece of work. It's usually then local activity, but I suppose it's that golden thread that comes through. I think that sort of looking at from a patient carer involvement, probably could do a little bit more work around that, but I think that those are some of the plans. Plus we're also now, as Victoria knows, our main audit activities around, it's linked to patient safety. So we've got 6 key clinical audits that we're looking at now. So just to give you some feedback on what we're doing, where we are.
Yeah, no, that sounds really good. Is there anyone who is thinking to themselves they would really want to try and improve that relationship and improve the way that they work? I don't know if there's any particular challenges that people have got that they'd be willing to maybe share or highlight. Is there anything that's preventing you guys from doing that? There was a couple of points raised earlier about the systems that we use in order to record obviously the clinical audit activity, but also the patient safety activity. It looks like some organisations, they have a system for clinical audit, and then they've got a different system for patient safety. How do we sort of bring those two together? I'm not sure that there is a system that does cover all or talks to each other. Does anyone want to contribute anything in relation to the systems that they use? Carl?
Thanks, Jordan. One of my biggest gripes is, if you like, is how we say quality and safety. When patient safety is one of the 3 key elements of quality. So I think the language and the structures is a big barrier, I think, in terms of how we all work, and different exec leads of different portfolios across each of the trusts, as I've just put in the chat, really. So but ultimately, when you're in your trust, we all work in one team, and we all, work for the patient, safety in mind. So I think, don't go with the hard sell on clinical audit or any other improvement activities that you want to work with them for. Is just actually try and think of some commonalities that you've got. Take, for instance, we've just been looking at patient falls. We felt during the pandemic, the patient falls on the wards were going up because relatives weren't being on there, so that they were getting out of beds less and things like that. So, but actually, we've looked at it and trended it through the number of incidences and we've had, and it's just actually anecdotal. That sort of thought was. So, but without a doubt, looking at the serious and untoward incidents that we now report nationally, etc., there is lots of learning from patient safety reports that we can actually put interventions into to make sure that we learn and make sure that it doesn't happen to other patients. So I think absolutely make sure you have strong links with your patient safety teams.
Yeah, definitely. There was one more thing as well, which I sort of picked up on as well as we were going through the presentations and in the chat. And I'm hoping that I'm not picking on anyone in particular here, but I did notice that there was a couple of people who mentioned the patient safety incident response framework and how they've been early adopters of that. And I'm sure there's lots of organisations out there who have obviously come across it and are perhaps thinking to themselves, oh, you know, we need to sort of build that into our clinical audit activity and what have you. And I'm just wondering if anyone who has been able to do that and who is looking at the patient safety incident response framework, if they would be willing to mention what they're doing and how they've been able to embed it. I don't know if anyone would volunteer to talk about that.
Yeah, let's see if any hands, Jordan.
No.
It's a challenge, isn't it?
It is. That's all right. Not to worry. I noticed there's a couple of people mentioned it in the chat. I'll be honest, it's not something that we've really looked at in depth here. It's something that we're probably going to have to look at in greater detail. You know, it is coming. But yeah, I did see in the chat that there was a couple of people who had said that they've been able to adopt it or you know, embed it, and perhaps they'd be willing to for people to email them perhaps and find out a bit more from them and their organisations.
Well, that'd be great. I was going to ask a question, Jordan. If you've got quality strategies in their organisations, because obviously their quality strategy should have their all arms of their governance, and just thinking about within that there must be some patient safety objectives and then your clinical effectiveness objectives, and actually they're aligning and pulling out your key priorities. How well are you aligned within your quality strategy, maybe in your trust quality objectives? Anybody willing to share? And then on top of that, I was thinking, how big are your clinical audit programs? And how many audits on your programs have you actually got that are driven by patient safety?
I think with ours, there's probably a lot that are driven by patient safety, but I'm not entirely sure whether we are perhaps clearly identifying those which are related to patient safety. You know, say for instance, as part of the registration process, are we saying explicitly that these relate to a patient safety incident? I wonder how many people have that built into their registration process, and then you can easily maybe pull that out for bespoke reports, etc. Because I imagine a lot of audits, if not the majority, probably do relate to patient safety, but how many of them are explicitly in response to, say, for instance, an incident that's happened, you know, on a ward or in a department? How easy is it to pull out that information? Obviously, depending on your database, etc.
And that's really about getting to the bottom of the key driver for that project, isn't it? Why this audit? Why now? We all know, as the clinicians that are on the call, that you'll attach clinical risk to everything, won't you? You'll tick that box on a registration form. Yes, this is a clinical risk. It's got to be done now. But yeah, as you start to unpick the background and why it needs to be done, actually, is it a true patient safety concern at this time that we need to then resource to review and take action on? Okay, have we got any other questions? Just thinking, Jordan, that people might be sat with a burning question to ask at this point in time.
I mean, feel free if anyone's got any questions. We've got a couple of minutes before the closing remarks, haven't we?
We do. I know it's might be worth me sharing at this point in time what we do in Sheffield, because about 5 years now we've been formally risk assessing our clinical audit outcomes. I know we presented at the webinar that you organised last year, Carl, in terms of effectively utilising our local programmes, and we do risk assess any standard where it doesn't score 100% in terms of is there a clinical risk attached to that, and making sure that we assign a level of risk to it, goes on the risk register, and then we have an improvement action plan that really is about treating those risks that go on, and that we align it to if it's already on the register and that we already know that it is a risk in the organisation. So going back to some of the points that I talked about earlier in terms of do we know about this, and have we already got other improvement actions going on in the organisation so that we're not duplicating or actually having actions working against each other. So that's quite a formal process of assessing any level of risks in outcomes. And there are other organisations, I know within Yorkshire and Humber, there's other organisations that have a slightly less formal process of reviewing the level of risk, and they provide a level of assurance, whether it's limited, medium or high assurance based on the outcomes that are coming out. But we've all got slightly different processes, but it's making sure that we are aligning clinical audit and patient safety, and that it works and it fits with your risk management framework within your own organisation as well. It's just starting to think slightly differently. It's good that we're picking topics that come from patient safety and issues, or actually to flip it, it's also thinking about, well, actually we do an awful lot of clinical audit in our organisations that highlights really good practice, and maybe we should also be celebrating that to say, well, actually this whole programme of improvement work that we do is actually preventing avoidable harm as well in itself, and we've got the evidence to say that we're doing really well. Because we could go down the road, couldn't we, have constantly focused on what are we not doing right, and we've got to do something about it, and forget to celebrate the good as well, because we do every day. We do really well at keeping our patients and our service users safe as well. I think we've just got some my head of effectiveness at Sheffield has just popped in the chat as well. The approach naturally draws us to working more closely with our patient safety colleagues, and it does. We work very, very closely through that new process that was introduced. Just looking at the chat as well, Jordan. We've got some people saying that actually they've got similar processes in place.
Yeah, for those teams that are perhaps struggling to make inroads with, patient safety teams or risk management teams, if that even is an issue, I guess the subject of your clinical audit is a good way to try and make those inroads. Going to those teams and asking for, can you give me a breakdown of this? Can you provide a report on this? Datex is a wonderful thing. I think from experience, it can pretty much be made to do anything. You can really tailor it. It might be a good way for you to get in there with the patient safety teams if you aren't already working that closely with them.
I think that's brilliant. Thanks, Jordan. Okay, we've got a few people in the chat asking if today's session will be recorded, and it will be made available for you to share far and wide with your colleagues as well. So shall we move on, Jordan? Shall I move back to screen sharing?
Yeah, that's fine.
A little bit about the rest of the week. So today we've obviously very much focused on patient safety, but you can see here what we've got lined up for the rest of the week. So tomorrow we are looking at patient advocate. This will be chaired by Sarah Chesel, our NQI CAN General Secretary, who you'll have seen on the call today, and facilitated by Craig Short, who's our East Midlands Clinical Audit Network Chair. And we've got Kim Resel joining us, who is the Head of Patient and Public Involvement at HCRIP. She's the key speaker. On Wednesday, we're looking at influence and change. That will be chaired by myself again. And we've got Layla Gregory joining us. And she's the London Quality Improvement and Clinical Audit Network Chair. So she'll be helping us to facilitate that session. And our key speaker for that event is Sam Riley, who is the Director of Making Data Count at NHS England and Improvement. On Thursday, Our focus is on health inequalities, and Sarah will be chairing that event again, and she'll be joined by another Sarah, Sarah Byrne, who's our Mersey Quality Improvement and including Clinical Audit Network Chair as well. And then Friday will see us closing the week, Clinical Audit Awareness Week 22, with a Future-Proofing Healthcare Lunch and Learn. I will be chairing the event again. We've got Mojgan, who's our South East Clinical Effectiveness Network Chair, joining us to facilitate. And we've got James Mountford, who's the National Director for Improvement Strategy at NHS England and Improvement, joining us as well. So that should be a good session to really sum up and round up the whole week, and setting us some challenges to take forward over the next year or so as we move into the next Clinical Audit Awareness Week. And rather than it just be 1 week of celebrating, we should be looking to actually making sure that we're making improvements and changes all through the year, and that we're recognising and celebrating as we go. So please do join us if you can. If you've lost the links that we've circulated or we've put out on Twitter, head over to the HQIP website and all the links are on there for you to access for each day. So really it's about us summing up now, I think, with a few minutes to go before we reach 2 o'clock. Final thoughts really from today's session. We're hoping that you will click on the link that's going to go into the chat for an evaluation form on today's event. We do value your feedback, things that you've enjoyed, that you've got out of the event, and also maybe things that could be even better if. Click on the link and tell us what you're thinking after you've joined this session today. Thanks for joining us and participating as well. Really valuable points that have been raised and discussed. I think clinical audit is absolutely integral really to driving the patient safety agenda. It's specifically mentioned in our patient safety strategy in terms of utilising clinical audit to make sure that we are actually learning as organisations from harm, especially where harm was avoidable. Let's be a bit more proactive and really utilise it to prevent that avoidable harm and keeping our patients and service users safe, whilst also looking after our teams as well, who are planning, commissioning and delivering patient care and services, because it does impact on us as well when things don't go as well as they should have done. So like I said, click on that link. I'm going to challenge you now to go away today and have a look at how clinical audit aligns to the patient safety agenda in your own organisation. Would like to thank all of our speakers for today and everybody that's joined us as well. It's been a really valuable session. It has been recorded, as we say, and we'll share that link with you so that you can listen to it again and share it more widely. So good luck. We look forward to seeing you submitting clinical audits for patient safety in the future. Sharing on the National Network and Sharing Forum and more widely within your networks as well. And don't forget to access those links in the chat to join if you're not already a member of your network or you're not already a member of the forum. So have a lovely afternoon, and we look forward to seeing you all again this week in the Lunch and Learns. Don't forget to be tweeting out and emailing and sharing as best as you can within your networks and with your colleagues. Thank you very much and have a lovely afternoon.